All right, fantastic. So precision medicine is a hot topic, and I'll try to highlight what this truly means. We've been talking about personalized medicine, myeloma being a very heterogeneous disease, and different myeloma patients being different, not just based on their age and comorbidities, but the fact that the features of their myeloma, the biology of the disease, the kind of genetic mutations or chromosome abnormalities they have is going to be different. So we recognize that myeloma is a very heterogeneous disease, but we're approaching treatment in a very one-size-fits-all fashion. What precision medicine really means is we want to now move into a way of customizing treatments for myeloma patients based on the molecular subtypes or genetic mutations they may have. So how can we achieve that? We can try to learn more about the cancer by doing specific tests on the genomic material inside those cancer cells. Genomic testing could be gene expression profiling. It could be whole genome or exome sequencing or next generation sequencing. And these are all fancy things that Dr. Google can explain better. But gene expression profiling looks at the expression of different genes present in a specific cell. So in this case, it would be malignant plasma cells. There are roughly 30,000 different genes in every human cell. And depending on which genes are active and which genes are inactive, the cell takes the form of a heart cell or a brain cell. So what we're really looking in these malignant plasma cells is expression of those genes, whether up or down, and how that correlates with how they will respond to different drugs. The whole genome, exome sequencing, and next-gen sequencing panels look at specific mutations of a gene that result in either that gene becoming non-functional or over-functioning. So based on some of those results, you can tailor therapy because we are heading into an era where we are developing treatments that will be beneficial for certain subgroups of myeloma patients more than others. We've already heard a lot about the venetoclax data, the BCL2 inhibitor that is going through clinical trials and will likely have its accelerated approval in 2018. So this is an example of a very good example of personalized medicine. And this comes from the COMPASS study experience. So we've got two patients, two women, very similar in age, 72 and 71, ISS stage 2, got VRDS treatment, had similar cytogenetic abnormalities when cytogenetics were tested by FISH, but the time to progression was 1 month in the first patient's case, and it was over 18 months in the second one. So why is that? The ISS staging is fine. We check the FISH features. They're about the same. So what's really happening? Well, FISH only gets to a certain level of detection. It doesn't tell us the kind of gene mutations the cancer may have beyond that karyotypic abnormality. So when looking at the tumor suppressor gene P53, in the first patient's case, that gene, a tumor suppressor gene was mutated, so it was not functioning, whereas it was not mutated in the second patient. So even though there was deletion of 17p, the leftover P53 gene was still functioning, and that is where that the heterogeneity within deletion 17p patients comes into play. So all deletion 17p patients are not the same, and the mutation of the residual gene or the gene that's left over in the cancer cell determines how patients are going to behave or how the cancer is going to behave. So this makes a strong case, and this is just one of the many lessons that we're learning through the COMPASS study. And this was a landmark trial looking at close to 1,000 myeloma patients followed prospectively, and they were getting very comprehensive genomic analyses done at the time of diagnosis, when they're going into a good response, and then when they're relapsing. So what you want to learn from that experience is not just what's happening to them based on their original disease features, but how disease features are being modified under duress or under duress of treatment, and as they're relapsing. So with that experience, what we've come to know through precision medicine efforts and learning about myeloma genomics, that there are several different genetic alterations or mutations that are more prevalent in myeloma patients. And several of these actually have drugs that can potentially be utilized. Now, myeloma is not a one-pathway disease. This slide kind of represents that. There are several different mutations that can happen in myeloma patients. These are not exclusive to myeloma. They also occur in other malignancies as well. But now we have different drugs that can potentially be utilized for these patients. A good example is that of a BRAF mutation. BRAF was identified in the original myeloma sequencing paper that was published in Nature almost 6 years ago. And then, vemurafenib is a BRAF inhibitor that was utilized in a BRAF mutated myeloma patient, and this case was reported 5 odd years ago, showing that in a very aggressive, advanced myeloma patient, the BRAF inhibitor actually resulted in a complete response that was durable in that specific patient. And this case was published, I think, in 2012 or 2013. But this just gives you an example of the potential for these precision medicine or targeted therapies. So taking that into account, the Multiple Myeloma Research Consortium is developing an umbrella protocol utilizing precision medicine. We already have a molecular profiling protocol through which we are doing gene mutation panels on our patients within the MMRC institutions. And the idea of this particular trial is going to be focused on high-risk patients who are relapsing early. They've already had their profiling done. We know what kind of mutations they're going to have. If they do not have any actionable mutations, they will get a backbone regimen. The question of checkpoint inhibitor treatment is up in the air because of the recent FDA data, but they will have a backbone regimen. And if they have one of these mutations, they will have an addition of that particular mutation inhibitor along with the backbone regimen. And we are hoping to open this protocol sometime in 2018, and this will be the first step towards getting to a precision medicine-based treatment strategy for high-risk myeloma patients. There are already other precision medicine clinical trials. I think you've already seen this slide from one of Dr. Voorhees' presentations. So at our center, we have this ASCO taper study that is actively enrolling. LCI has been one of the 3 key sites in ASCO taper. There are several other efforts that have essentially given us the experience to develop a myeloma-specific precision medicine study. So these are exciting times as we start towards personalized medicine treatment strategies for myeloma patients. And kudos to the Multiple Myeloma Research Foundation, and we can pat ourselves in the back a little bit with the MMRC institutions in general. I've tried to wrap up my talk quickly so that I can take a couple of questions. We want to move along with some of these topics so we can give you guys as much time for the Q&A session. I would actually ask Ajay if he can look at that question list and throw a couple of questions at me.
That fit this, for the precision medicine talk. Very, very interesting question. With the heterogeneity of myeloma mutations at different sites in the body, how can we rely on the biopsy of a single site to diagnose the risk level? Will blood biopsies overcome this problem?
I think that's a fantastic question. So historically, we've relied on the pelvic bone marrow biopsy because of ease with which the biopsy can be done compared to trying to sticking a needle in the vertebral bones or the skull bone, etc. But But myeloma is a heterogeneous disease. Even within a given patient, you may have different subclones that are proliferating in different parts of the bones. So there are efforts underway in trying to understand disease biology with cell-free DNA, which can be drawn from the peripheral blood, or in certain cases circulating malignant plasma cells. But those technologies are very early in the game. Back when I was in Arkansas in 2011, there was a study that was presented as an abstract showing that gene expression profiling done in a myeloma patient from the random bone marrow aspirate and a focal lesion, there was roughly 80 to 85% concordance. So the molecular profile of those malignant plasma cells taken from the same patient from two different sites was about the same in about 80 or 85% of the cases, but in 10 to 15% of the cases, it was different. And there were, and in some of those instances, patients had low-risk disease in the pelvic biopsy, but high-risk disease in the gene expression from the focal lesion. So there is some discordance. It's not huge, but it's there. And one would expect from disease, nature of disease biology and how it progresses for that to be true. I hope that answers the question.
Yeah, there is a second question. I think the question is from the Castor and Pollux trials. Is there any subgroup analysis on mutational status?
There wasn't subgroup analysis on mutational status, but cytogenetics and FISH analyses were done prospectively and centrally in those studies. And what was observed, so for people who don't know what this Castor and Pollux trial is, these were studies of the monoclonal antibody daratumumab, either combined with Revlimid dexamethasone or with Velcade dexamethasone, compared to the standard of care of Revlimid dexamethasone or bortezomib or Velcade dexamethasone in patients in early relapse. So if the patients are relapsing for the first time or the second time or the third time, that was the group where there were these two big randomized phase 3 studies done. And in those studies, cytogenetics and FISH were acquired at the time that patients were going on study. What was observed in general is that addition of daratumumab does improve the outcomes of high-risk patients when compared with the standard arm of the two drugs. The high-risk features are not overcome completely with addition of daratumumab, but there is an improvement in survival outcomes. And because this was not something that was a planned analysis for the study, I would limit my comments to that, to that observation.